So these things will come into play very soon for chronic pain management. So pain interventions will bridge the gap. It's a targeted therapy, not like whatever you drink or you inject. It will go all around the body then, and on the target, it will point percentage will reach the target. Whereas pain interventions will reach the target 100%. So get more targeted treatment, safe, but they are invasive procedures. So you need some skills to do it. You need image guidance. First, was supposed to be a problem, but now take neuropathic medications like pregabalin, gabapentin. 1 month dose of that will be less than, more than this. So intervention will be cheaper than the treatment actually, this treatment. The main problem is actually we don't have that many randomized trials because we can't do a sham process, inject water into one person, medication into other person and do a randomized trial. It's not possible. So there is randomization and things coming to play. So we don't have that many randomized trials. But anyway, now evidence is building up. So we have a lot of controlled trial evidence to do certain pain interventions. The most important thing anyway is the right diagnosis and the right procedure. If you rightly diagnose the patient, get a wrong diagnosis and try to do something, the interventional things, you only get complicated. If you have a wrong procedure, maybe you are having 3-4 procedures which can be done on a single person for that diagnosis, still you have to individually tailor that whatever therapy for that patient, specific patient. So otherwise you will get complications. So you need some experience as well in doing that. So this is the basic recommendation chart. So up to point 2B plus will be recommended for patient care. So we have large amount of actually evidence now for various pain scenarios, from trigeminal neuralgia, cervical radiculopathy, cervicogenic headaches, all these things. So we have hundreds of now recommended indications for pain interventions. We're not going to go through all that because of time constraints, but in summary, for diagnosis and management of chronic refractory pains, we certainly have these interventions done for spinal pains, non-spinal pains. Spinal pains are common, as I said in the previous slide. So in the spine, we can do facet interventions, disc interventions, vertebral interventions, intraspinal interventions, non-spinal, myofascial. This is the commonest chronic pain scenario actually, which is very easily treated with interventional pain management. Then joint and enthesiopathies, peripheral nerves, sympathetically mediated pain, CRPS, as I was describing earlier. So let's go through one interesting case, and then it was go through other cases as well. We'll see with time. Now this man actually was 61 years, 1 year old man who presented to me with severe low back pain, which was going on for 4 to 5 years. The pain score was about 8 by 10 when I saw him, and he was having sciatica on left side more than right side. So this fellow was going around the country, has been seen by many neurosurgeons. Ultimately, he was asked to get a spinal surgery done. He refused that because he had some bad experiences and previous appendicectomy or something, which ended up with 2-3 days ICU stay. And then ultimately he came to me. The time he came to me, he only had actually no neurological impairment, had just pain issues. Severe back pain radiating down more than the leg pain, rolling in a spider root actually distribution. So he had an MRI scan done, which actually had shown 2 bulging discs. Mind you, MRI is not giving everything. We have to interpret MRI in the whatever patient's context. All of us after 35 will have some bad discs in MRI. So we will have to always interpret if that bad disc is causing your problem or not. Otherwise, it will end up as a failed neck surgery. So when we assess actually, he had all these things, and this is common to all spinal pains actually. Now, in the spine, the whole thing, like the 2 vertebrae, the disc in between, and the facet joint in the back, they work as a locomotive unit. So when one is dysfunctional, when the disc is gone, facet will be more strained. When the vertebra is gone, disc and facet both are strained. So you get one, whatever element involved, the other element should be automatically involved with some sort of pain problem. And on top of that, there will be certain muscles on top. Those will be strained, and they will get myofascial pains. So this patient similarly had basically myofascial back pains with trigger points. He also had facet joint element on examination, and he had bilateral sacroiliac dysfunction, which is an associated joint, and he had displaced flow back pain with sciatica. So he had all 4 components. So this is very common for all spinal, neck pain, back pain, everything. So they basically come with all these things. So if you address just one thing by a surgery, you will come back with something else. So you have to address one by one everything. So he was already on analgesics.